friends, and respected elders. A few days back, Rajan, with an impish look in his face, told me that, look, I know all about you, you don't need to give me any introduction. So I took caution from that stage and drafted a few lines for him. The topic might as well have read this morning, the way through adversity. And when I was thinking about how to start off the deliberations today, I had to pick on the lines that were written about 100 years before I was born. Borrowing the opening lines of the aftermath of Paris after the French Revolution, Charles Dickens had started, "It was the best of times, it was the worst of times." Now let's discuss a little bit about the good times first. India being a land of slogans, the one currently going around says, "Achhe din aage." We think it's very new, it's very original, it's not actually, because it's a spin-off from Happy Days Are Here Again, which was used in Theodore Roosevelt's election campaign in 1932. And our Achhe Din started in May 1967, when this gentleman, René Favaloro, had the queer idea of stitching an upside-down piece of vein from the leg, from the aorta to the coronary artery, and thereafter, the good days had started, and somehow happy things happen in May, because 47 years later, it was in the May of 2014 that we were gifted with the slogan that Achhe Din Aage. So from the early 70s, we were really having a good time. We were witnessing a dream run, an uninterrupted honeymoon period of about 3 decades. Well, unknown to us, there were subaltern activities happening whilst we were in sort of good days and mirth. A certain Swedish youngster by the name of Andreas Grundtvig, between 75 and 77, had an even funnier idea of fixing coronary blockages by making holes in the groin. And in the 1977 meeting of the American Heart Association in Miami, perhaps luckily for us, the paper was thrown out. It was not accepted for oral presentation. Somebody from the scientific community had mercy on Andreas Grundtvig and accepted it as a poster. And this is Grundtvig himself in 1977 in Miami, actually standing in front of that poster, because that is all the hearing he got in a huge conference that was due to change your and my life forever. The angioplasty gave into stents and what have you. We do not have enough time to go through the evolution of problems. But gradually and surreptitiously, we got bowed down by a lot of data, by a lot of hodgepodge in terms of clinical trials. You had the Arts, the Barry, the Iraqi. I'll tell you a bit about it in a minute. Till the Prince Charming was delivered, and Prince Charming was delivered in the form of the cipher stent in the year 2002, and there begins our misfortunes. There was a bit of trickery. You know, Rajan mentioned somebody I'm not related to, the magician P.C. Sarkar in Calcutta, but there was a bit of trickery, and we, very simple-minded, humble surgeons, took about 5 years to suss it out. And the trickery that was happening is that the industry had sensed a kill. And what the industry set out to do in the earlier trials of PCI versus CABG, the entire powering, the primary endpoints were all towards looking at repeat revascularization and MACE events and so on. But whenever the going was not in favor, the data was not in favor in the earlier trials, they switched gears, and almost without exception, each and every major thing just said, the mortalities are comparable. And we accepted it. The first strong repartee, if mind science be right, from the likes of Bob Guyton was about 4 years too late. And industry, helped with this percutaneous procedure, had created a clouded consciousness by this time. till we move over to the wonderful creature we discuss ever so often these days, the syntax trials. We have David in front of us, one of the great participants of the syntax trial, who through 2008 and 2013 was perhaps the one and principal trial which was randomized, looking at patients for 5 years. Now, you all know a lot about syntax trial. My take-home message from syntax trial has been that about 30% of triple vessel disease with a syntax score around 23 has been lost to coronary surgery. My take-home message from syntax trial is that about a quarter of the entire surgical population of left mains has been lost to coronary surgery. So by this time, the boat has been well and truly rocked. Let us consider the global scenario. Let us consider life in 2002 and life as we knew it in a span of 6 years in 2008. Globally, we see a dramatic inversion of ratios right in front of our eyes. From a 70-30 domination of the market, we now are minority stakeholders with a 30-70 distribution, if at all, in favor of us. So in a matter less than a decade, the roles, friends, had been reversed. What is the European situation at this point of time? In Europe, if you look at Spain on one end, if information is right, Spain runs a ratio of 7:1 or 8:1 like PCI to coronary. If we consider the United Kingdom situation today, I believe the ratio is around 4:1 as far as PCI to CABG is concerned. What does it mean in the European context? If you do a little bit of health economical analysis into it, I hate using this cliche, which is called the Western scenario, but in lack of a proper, replacement, I have to. In the Western scenario, where the surgical penetration has reached a maximum, where health detection is at a maximum, you already have a finite pool of patients. So in that finite pool of patients, if your market share has dropped to something like 30% from 70%, there has to be a catastrophic decrease in numbers. And that's what perhaps has happened as far as the UK, the US, the rest of European scenario is concerned. Now, India takes about half a decade to catch up with most things. And what happened in 2002 across the oceans and across the waters? In India, we believe it was around 2007 that the PCI and the CABG graphs intersected. But look at another perspective. Look at the penetration of surgery in the Indian population. We are serving a population, something that Professor Prasad Rao just referred to in slightly different connotation, but it means the same. We perform about 90 to 100 surgeries per million population for a population of 120 billion people. As we aspire to wake up into good days and Achhe Din Aage, if we try to get anywhere near Taiwan, Hong Kong, Malaysia, South Korea, Japan, then that ratio has to be somewhere around 500 per European population. If you are aspiring to catch up with Europe, then that ratio has to be 700 per million population. And in spite of all the hammering that the United States has taken, if you want to get to the United States figures, you have to get to 1100 per million population. So, look at the other side of the glass, and that tells us that yes, our percentage share has fallen. But you and I don't operate on percentages, we operate on patients. So we have a falling market share in an exponentially increasing patient pool. So forget about the percentages. Okay, we take heed of it. But from the standards today, even if we try to do 300 operations per million population, we hit 300,000 procedures as compared to the 120 or the 130 we believe we are doing now. So that is my take on reality, that is my take on the situation as it stands today. The great medieval prophet of doom called Nostradamus, He very much, predicted the end of everything apart from two entities, which was the Congress Party and the BCCI. So Nostradamus, I am not giving into the Nostradamus complex that the ding-dong bell is up and the end of cardiac surgery or coronary surgery, especially in India as we know of it, has arrived. Let us reinterpret the figures and look at the future through a slightly different looking glass. Now, it is not very often that an Indian stands up and quotes William Churchill, because Churchill, if anything, was the last friend India ever wanted. But this man, being a great leader in adversity, said a great thing. A pessimist sees the difficulty in every opportunity, and an optimist sees an opportunity in every difficulty. And some of this, infective pessimism that we have going around all around has been exported by the so-called industry, who are without exception surrogates of Western entities and cannot interpret the clinical economic context, cannot see the world we would like them to see through our own eyes. I give you an industrial analogy. The great Morris Oxford, 1932, got implanted into India's ambassador car, used to be manufactured not very far from where we live in Calcutta. Now come the single hint of competition. In the mid-80s, the ambassador just disappears out of business. They cannot grapple with the challenges of the market because Maruti Suzuki has arrived. Great. What happens a decade later? Our automobile industry is opened up even further. The car sales in a matter of 2 decades have gone up by about 25 times. So this product adapts, this product innovates, and in front of tremendous challenges, this same company, having lost tremendous amount of market share, you've got competition from Korea, from Tata, from all over the place, but having lost market share, it has increased its turnover by a factor of 20. So what you and I consider today are not economically, industrially isolated phenomenon. After all, we happen to be a viable part of the healthcare industry. We have to carve out our due share. We do not hit the markets with AK-47 and grenades and what have you, mercifully not. So we have to hit the markets by applying the parameters of guidelines and evidence. And not just applying it from a distance, but what is tremendously important is that being hands-on involved in the process. Now, what do I mean by saying hands-on involved in the process? If we were to have a line of control, then line of control is meaningless unless the line of control is implemented, unless that line of control can be predicted. And the first method to do that is something we are ignoring tremendously today, is the aspect of clinical advocacy. In clinical advocacy, we have to be empowered by the evidence that exists in the clinical arena today in the form of trials and guidelines. And inasmuch I have enjoyed and continue to enjoy my period in the IACTS, I'm a bit worried by certain traits in its structure which makes it a very centralized kind of body. You and I live in a country which has 1,700 cities, Tier 1 to Tier 3 included. There are more than 200 cities in India which has a cath lab put in, and before the next 2 years goes up, there will be more than 600 cities in India that will have access to acute coronary care and cath lab facilities. So there will be a lot more Texan cowboys with catheters in their hand all over the place. What have you and I done to reach out in those regional outposts? Have we empowered ourselves to make our voices heard? I would request each and every member of IACTS to think of a structure that addresses the needs of the future. The dramatic results when syntax closed at 5 years. We have 90% superiority in MI, we have tremendous superiority in all-cause deaths, in cardiac deaths, and what have you. Look at this subsegment, the MACE events, for the simplest possible cases, the syntax score of less than 22, even then the revascularization rates are higher. And if you go through the more complex cases till the population with the highest possible syntax score, then the only treatment option where PCI can be compared to is perhaps the electric chair. But the problem is, who knows about it? Is this message being conveyed in an understandable, in a soluble kind of way? I remain unconvinced. In a country where every third person is diabetic, I bet on you that not more than 5% of physicians has ever heard of this animal called the freedom trial. And freedom trial has established the superiority of our form of revascularization in terms of death, MI, myocardial infarction, repeat revascularization. And not only it has done that, it has succinctly proven that this superiority is irrespective of the syntax score, even if your syntax score is -5. With surgical revascularization, the outcomes are remarkably superior. Yes, this data exists in the scientific domain, but the question is, does this data exist in the public domain, in the people who really need to know? Time has come not to fight violently, but to question the propriety of off-label CABG in diabetes, in triple vessel disease, in intermediate and high syntax scores. And the silence from the lambs has to be broken. And if we were to break it, it had to be broken yesterday. I would again implore the IACTS to set up a clinical advisory board where in a simple kind of way, it could be a simple booklet, it could be an app on your mobile phone, which gives to the curious customer, to the patient, to the physicians out over there, that what is the proper treatment. We live in a country which has used more cell phones than toilets. So what is wrong in having an app if a physician sitting somewhere presses a button and needs to know that in a diabetic with 3 blockages, what is the preferred form of treatment? It cannot be a secret of information anymore. We better reach out as soon as we can. And this reach out has to be in the form of a direct engagement. Don't depend upon your marketing people, somebody who who's totally clueless as to what they're talking about, to go out in the marketplace and spread these words of applied science. We have to get into the process of communicating with patients, of communicating with physicians. And this is what a marketing guru, I'm certainly not one, will tell you what a B2C, a business to customer, and a B2B, a business to business communication is more about. We have to climb down from this cozy position, because otherwise we will not be able to give up this cloak of accepted surrogacy when you and I, again to borrow Charles Dickens, end up looking like a pitiful Oliver holding a little bowl and in the sort of thing in the dining room, walking up to the master and saying, "Sir, can I have some more? We've had enough of it. Let's change tracks." We have to retrain. And of all people, we've had great conversation with my friend Vivek Jowli, and this was another example of great minds thinking alike. When we have said that it is already time is overdue when all our training programs, surgeons in practice, trainees in practice, will have to acquire relevant catheter-related skills. How we do it is our problem. We have to accept that the only thing constant in life is change. Now, there are a few worries. And one worry is that about 80% of our work is getting done in 20% of centers. How do we address it? It had to do with the reimbursement mechanism, the advertising mechanism, but with perhaps more and more access of patients to public and government insurance schemes, there is an avenue for this to change. And what is really hurting, I'll talk about it, refer to it in a minute, is when we embarked on the national registry programs and we requested centers to file in their numbers. It was very difficult. It was like doing a tooth extraction in a shark. So we gave up that idea of having center-wise numbers, and we now have regional numbers. But it is those moderate, those smaller, those expressing centers who needs their figures to go up on the scoreboard far more than the larger centers do. So my request to you is, please see into the wisdom of reality. You cannot hide away from reality, because if we are able to show whether it is 25, 30, 45 cases that is happening with good endpoints in a center, that is what helps you to establish your credibility much faster than wasteful marketing. Cost. Now, after a lot of serious talk, it's time to break into a story. And the story is about a Frenchman again, and this Frenchman was Dominique Jean Leray. I don't know how many of you remember Dominique Jean Leray, perhaps no one, simply because he was the chief surgeon of Napoleon Bonaparte. Now, why was Dominique Leray that famous? He was famous because he was able to do the world's fastest amputation. That was the commonest surgery required in Napoleonic wars and Crimean wars in those days. And his surgery had a specialty, that he was so fast, he would chop off the limb, and along with it, usually he would chop off 3 fingers of the assistants. This is something he did on a regular basis. And this is exactly what some great surgeons have done to our specialty. We have done fantastic clinical exercise and chopped off some vital parts from the vitality of our profession. We have cut cost to perfection and perhaps in the process cut the vitality of our specialty. So much so that cardiac surgery has become like selling redundant soap boxes in Big Bazaar or somewhere. It's a naturally discounted event. If you cannot clinically interact with a patient without mentioning the word discount, that interaction is a failure. It has become embedded in the DNA of a clinical counseling. We have 30% of the market share in numbers. The coronary practice, the cardiac practice in India today is valued at somewhere around $600 to $700 million. You and I will not feel very happy to know that we only control 15% of the yield in terms of the surgical turnover vis-a-vis business. So this is where the disconnect gradually has to resolve. And this is the cause why our young men and women are finding it so reluctant and they are so hesitant to walk into this specialty with a lot of spontaneity. What has been the effects? Poor viability of cardiac surgery in private hospitals. Yeah, I go on saying private hospitals all the time, because just referring to something Professor Rao said in his deliberations, very rightly, Indian healthcare today is valued as a $180 billion business. And the more we grow, we have the entire healthcare in India has a year-to-year growth rate of about 19 to 21%. And in this, the more we do, the more is the involvement in private sectors. I'm not supporting it, I'm telling you a fact. And the more we do, the greater is the reimbursement or payment from the out-of-pocket system, which again is not a very healthy healthcare statistic, but that is reality for you and me. So we have jeopardized the viability of our practice. There has been compensation freeze for surgeons, quality, innovation has gone for a toss, and there is, I sense, amongst a lot of units, refusals to take up high-risk cases, which is worrying. So what am I trying to tell you through this cartoon is, not only have we given in to the jugglery of trials and statistics, but we in India somehow, like the mice following the Pied Piper, seem to have fallen into the trap that has been laid for us. And now we wake up to a syndrome where we have smiling patients and sad surgeons. And if there was to be a comprehensive study today, then the 10-year survival of patients would be much better than the 10-year survival of surgeons. What do we need? We need a cost consensus. We need our organization to come up and pull up data that each one of us have and have a large data bank going into 40, 50,000 patients and post a consensus document on our website, on our web, which of course will not be legally binding, but that will be the starting point of many a conversation. That will be the starting point of many a fiscal process, that somebody somewhere cannot pounce on you and say, that's everything put together, you are supposed to do a mitral valve replacement for 50,000 rupees. So on the professional forum, there has to be an amalgamation of data which is properly analyzed. We've taken baby steps towards it. My friend Rehan Saeed from Bangalore has given us a document which I've posted to many of you, and Rajan will post it on the website. Let that be the kernel, let that be the nucleus from which the cost consensus movement starts. As if the cost problem was not enough, we are perhaps the only clinical surgical specialty on face of the planet who's playing a soccer match with moving goalposts. Because exactly the same set of things that used to be a contraindication for the 80s has become a major indication for coronary surgery today. So with the indications of surgery moving towards the extreme, our oversimplified postures towards cost, etc., is very dangerous, and that will compel clinicians to cherry-pick cases which will not reflect well for us in the long term. This is perhaps not just a national issue. This problem is a kind of South Asian syndrome, and our disproportionality on how we are addressing clinical coronary artery disease, the fiscal eclipse of cardiac surgery, the lack of advocacy in the region has spread over the South Asian countries. And it is with recognition of these pressing criteria in mind that we will be fortunate enough to meet tomorrow with our friends who are here from Pakistan, from Sri Lanka, from Bangladesh, from Maldives, from Nepal, from Bhutan, and put together the South Asian Forum of Cardiothoracic Surgeons, whose main idea would be beyond fellowship to identify where the shoe pinches and what are the future directions to take the specialty forward in this region. Super surgeons, unfortunately, have the habit of being super secretive. And for years and years and years, as far as I can remember, we have been discussing database till the end of a string. But I, being a certified idiot, decided or thought that it was necessary to crawl first before we ran. And hence it is important to document somewhere in a reproducible kind of way that what actually was the number of procedures we were doing in this country. And that is the concept of the National Registry. If we get into the habit of just getting out after a day's work and saying, today I've done one coronary, one mitral, blah, 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 whatever, and just stick it in my diary, and we are able to file this data every 3-4 months, that will be a great habitual improvement in itself. And without any sense of shame, we are gathering parallel data from the industry because industry has a lot of information. And if you divide A by B, we are dividing the data from the surgeons by the data obtained from the industry, which is remarkably accurate, believe you me. And we are calculating what is called the compliance. It is the compliance ratio that points to you and me in a very merciless kind of way that how lazy we are in putting the data forward. But a start has to be made, and we are not ashamed to fail. This is how we have drafted the registry programs. We have 12 friends in 12 cities who every 4 months, in a simple enough form, is just capturing the data of procedures performed, no surgeon's name, no institution name, no mortality, no grafts, and we have to do this very simple, primitive exercise at least for the next 2 years to come. What has our data tells us? It shows us some good news. It shows us that from the period of July to January, in the 8 months, we've had 2 separate installments of registry data collection. And there is good news for us because in these 2 slabs of 4 monthly data collection, there has been a real-time increase of more than 20% of the procedures performed. So why are we shying away from it? So what we discussed a few minutes earlier, that we have the potential to perform 300,000 cardiac procedures in this country, was definitely not hallucinogenic. At this rate of growth, you will hit 300,000 procedures well before next 4 years. So why are we so reluctant? Why are we so hesitant to see these factors emerge in front of our eyes? This is the rough distribution of how the workload stands today. 56% about coronaries, 27% valves, 15% congenital, and the rest. So as we walk up the data path, let us pledge to have a data submission rate of around 70%, if not more. And honestly speaking, I believe that only when that criteria is reached, that we can consider ourselves to be mature enough to get into the database. Academic silence. Yes, it has almost been perfect. And there was a valid reason for it. Because you and I have been tremendously busy to put bread on the plate, to get the wheels, the nuts and bolts of the institution running. But in having to do so, our over-preoccupation with the mundane has resulted in a few very sad events. That the academic silence from South Asia and to a certain extent from South America has virtually crippled the data obtained from one great thing we did over the last decade, that was off-pump coronary work. There is no robust data at all available from 2 regions of the world who has perhaps done the most work. And we are trying. We were discussing with Professor Taggart David yesterday, that what about doing a RCT of ourselves? There are pros and cons to it, but the endeavor is still on. So the off-pump rates, that not too long ago we were tremendously proud about. You know, we were flying the flag of 80%, 90% off-pump, etc., etc. We have not been able to communicate to our co-professionals that what is the strength of the procedure. So from the stratospheric heights of 90%, as per as the last 4 months data concerned, we are lingering somewhere in the 40s. We are not doing a great service to ourselves by hiding what we should have displayed. Enough of pessimism. No pessimist has ever discovered the secret of the stars, or sailed to an uncharted land, or opened a new doorway for the human spirit. And these are the words of a lady, the great humanist of the 20th century, Helen Keller. If anybody knew in life what adversity was, she did, because she was deaf and dumb and blind. So we remind ourselves that we have to seek light through wherever it appears a bit foggy today. And we congratulate our colleagues who've been scaling very difficult surgical terrains over the recent times. We congratulate our colleagues because though we do not have the hard numbers for it, but the sense tells us that perhaps 2014 has been the best possible year for heart transplants in India. We have emerged into the assist devices. There are units across the country who are doing great work and good work in aortic surgery and in complex congenital work. So we owe you a large debt of gratitude for not only increasing the stature, but increasing the essential spectrum where cardiac surgery in India needs to be today. Friends, for the future, for tomorrow, it is a combination of strategy, advocacy, training, fiscal consensus, and regional cooperation that will help us to see our profession from turbulence to tranquility. I'm grateful to all of you who gave me the opportunity to stand in front of you today. An association is not fulfilled by its size or its numbers. An association is fulfilled in meeting the challenges of the present and the aspiration of every one of its members. I've had great friends, great colleagues, without whose help and assistance some of these very initial steps that we have taken would never have been possible. I've been truly humbled by the opportunity to serve. Let's move ahead with faith and purpose. Thank you.